All right. Looks like we got a pretty good crew here. Let's go ahead and get rolling. Thanks everybody for coming. Really appreciate you giving us a little bit of your time on this Thursday evening at 7:30 Eastern. Everybody on the East Coast. So let's get rolling so we can get you off to bed so that we can improve your longevity. My name's Dr. Mike Mallin. I'm a precision medicine and longevity physician, and also Chief Product Officer at TruDiagnostic. And we're going to be talking today about our new report that we're releasing called the TruHealth Report, which I'm really excited to talk to everybody about. I think you're all going to be very, very excited. So, as many of you know, True Diagnostics' focus has been on biological age and all the lifestyle factors that go into aging. And we are the leading epigenetic age company on the market. And you also are probably aware that our focus on science and research, large data sets, and our relationship with some of the best research universities. But we're not talking about aging today, at least not directly, because what we've been working on is something huge, something that we believe is going to change the face of medical diagnostics, possibly forever. Imagine for a minute a test that with one finger stick, obtained at home, can offer you over 100 epigenetic biomarkers, specific reasons for disease, and personalized interventions to reverse or prevent disease. A single epigenetic test that reviews over 100 epigenetic biomarkers covering a wide range of health processes such as vitamins, lipids, metabolic health, immune health, neurocognitive markers, all in an easy to read, actionable format. It'll help you direct your patient's health like no other test. Now, those are just some pretty big claims, I recognize, but that's what I want to talk about today. Is I want to back up those claims. And before we get too deep into actually going into the research that we've utilized to develop this test, let's take a minute and review just for a moment what epigenetics are, because it's going to be important when we talk about epigenetic biomarkers. So, epigenetics is the study of changes in gene expression that are influenced by environmental and lifestyle factors. So your genetics may not change over your lifetime, but the way your body expresses your genes does change. You can think of your DNA as an ingredient list for a recipe. And if your DNA is the ingredient list, then epigenetics are the instructions on how to make that recipe. Depending on what instructions we use, those instructions can create wildly different final products. You can throw it in a blender and get a smoothie, or you can put it in a crust and end up with a pie. It's the same principle with cells. If our DNA encodes certain proteins, we get a neuron. But if it encodes others, we end up with a fibroblast. The neuron on the left has the exact same DNA code as the fibroblast on the right, but their epigenetics are different. The neuron needs to make different proteins from the same DNA that the fibroblast does, and that's really what epigenetics controls. So epigenetics works basically like a light switch, and it can turn on or off each gene in your DNA so that that DNA is being used to make a protein or is not being used to make a protein. And we call this methylation because that portion of DNA gets methylated, turned off, or unmethylated, turned on. And methylation is really just the addition of a methyl group of that particular molecule to a specific location on the DNA right before that gene, telling the cell not to express that gene. The molecule, that methyl group, is what causes the DNA to sort of ravel itself up. So the DNA is methylated and it ravels up into a ball and it can't be expressed. If it's unmethylated, it unravels and it can be expressed. Basically, we're just measuring if the DNA is raveled up or unraveled and determining whether it's expressing that gene or not. You guys know this, but whether your DNA is methylated in a certain location depends on a combination of your parents' lifestyle, your lifestyle, what you eat, how you exercise, the medications you take, and literally every other factor in how you live your life now and how you've lived it up to this point. Seriously, everything, even listening to this presentation changes your epigenetics. So if we think about different omics and we take a step back and broaden the concept to beyond epigenetics, we've got DNA, epigenetics, proteomics, and metabolomics. DNA determines your specific genes, epigenetics determine which proteins get made or the proteomics, and then metabolomics are the end products of the biological pathways that the proteins actually control. So DNA doesn't change at all, and metabolomics change very rapidly. And there's sort of a spectrum of how fast these biomarkers change, from DNA not changing at all to metabolomics changing really rapidly. And traditionally in medicine, we're measuring proteomics and metabolomics. Those are the traditional blood markers that we measure when we send somebody to the lab to get their blood test. So if we think about multiomics and defining risk, let's take an example, thinking about specifically CRP. So remember we said the DNA for CRP is static, and you can have variation in your DNA for CRP, like you can have SNPs in your CRP gene, and the result of that is going to be a predisposition to higher or low CRP levels. In the same sense, you can have variation in your epigenetics, and that does change over days to months. So it's not static like DNA, it actually changes days to months. And that could be something like, for example, smoking inducing DNA methylation. And the byproduct of that is increased CRP levels. And then you've got proteomics, which changes over hours to days. And an example of that is IL-6 inducing CRP protein synthesis. So there's some inflammation somewhere in your body, white blood cells create IL-6, CRP gets upregulated, and then CRP peaks in the blood at about 24 to 48 hours. And then you could have a metabolomic risk example, which is going to change over minutes to hours. And that would be, for example, oxidative stress from inflammation. And in this case, we could measure elevated lipid peroxidation products due to the elevated inflammation and CRP levels. And we can, if we choose, measure any of these data points. We can measure DNA, epigenetics, proteomics, metabolomics. We can measure the CRP levels, the lipid oxidation, all of those things. The challenge comes when we consider the timing. If we're trying to diagnose an acute infection, maybe protein levels make the most sense. Maybe we should actually measure the CRP levels. But what if we're just trying to define risk or diagnose a chronic disease? The challenge is that we may only see our patients once every 6 to 12 months, and we may want a longer term picture of their CRP. One advantage to epigenetics is that it appears to have a longer time frame when evaluating a specific biological process, giving us a look into how the patient has been spending the last several months rather than just the last few hours. So considering this, we imagined what would it be like to sort of have a hemoglobin A1C for every biomarker, for CRP, for white blood cell count, for triglycerides. What if we could understand the normalized value of that biomarker over weeks and months rather than a specific time point when their blood was drawn? So what we're talking about is creating epigenetic biomarkers, a CRPM instead of just a traditional CRP. Epigenetic biomarkers are trained against the actual biomarkers and the diseases we're most interested in. A CRP that averages all your CRPs over the last weeks or months rather than just an acute CRP at one timestamp. And what we're talking about now actually exists. So this study was published or is about to be published. It's currently in preprint that we performed with Harvard University, leveraging DNA methylation to create epigenetic biomarker proxies that inform clinical care, a new framework for precision medicine. So I want to talk about this study for a minute because this is really the backbone of the test that we're talking about today. So in order to perform this study, we had to derive epigenetic biomarkers. And to create these epigenetic biomarkers, we started with basically training an AI algorithm against the MG biobank of about 5,000 participants. And we used the following data. We included epigenetics, clinical biomarkers, proteomics, and metabolomics. We validated that algorithm against the TruD data set biobank, as well as reverse validating it back against the MG biobank as well. And just to get into it briefly, what we did was for each biomarker, like let's take, for example, CRP, which we're sort of picking on CRP today, we looked at the epigenetic fingerprint for that biomarker and how it changed when that biomarker was low, high, or average, normal. And what we did is we took each one of those patients, looked at their different biomarkers, categorized them into high, elevated, low, and normal. And then we were able to basically create an epigenetic fingerprint or understanding of how your epigenetics change when your CRP is at these different levels. And we did this for a little over 3,000 possible biomarkers. And this included things like clinical values, proteins, and metabolites. So it looked like this. We took those 3,173 biomarkers and we basically put them into an AI pipeline and we looked at the correlation or the Spearman correlation between those biomarkers and the patient's actual traditional blood biomarkers. And we only kept the ones with a Spearman correlation that was greater than zero point 0.2, which is sort of a standard assessment of adequate correlation between two markers. And here's that data there. So What we're looking at here is called a violin plot. And really all it does is just describe the effect size or the correlation size between the predicted epigenetic biomarkers and the traditional biomarkers. And we broke it up here into clinical outcomes, metabolites, and proteins. And you can see that they actually perform, some of them have performed quite well, especially the clinical outcomes where we have Spearman correlations up in the 6 and 0.6 and zero point 0.7 range, which is phenomenal. But still, all the ones that we're showing here are all above that zero point 0.2. So we extracted all of those EBPs or epigenetic biomarkers that did not meet that threshold of zero point 0.2. And what's interesting here is that a lot of the variables where we found LoRa correlations are actually tests that are only performed fasting. So it's sort of interesting to think that we would actually expect to see variance there because when we're looking at an epigenetic biomarker, we're looking at, you know, that marker over time of weeks to months, as opposed to just a single fasting level. So, your glucose isn't always your fasting level of glucose, right? It's not always 85. It's often 110. It's often 130, depending on what you just eaten. So when we look at that area under the curve for each one of these values, we actually see some variance there, but it makes sense based on the fact that it was fasting or not fasting. So next we took once we identified that we had good correlation with these markers, then we looked at how well they correlate with mortality. And what we're looking at now is called a volcano plot. And this allows us to visualize the relationship between the hazard ratio and the statistical significance for a specific biomarker and its outcome. So on the left-hand side, what we're seeing is the volcano plot for the epigenetic biomarkers, the ones that we inferred based on epigenetics. And then on the right is the traditional biomarkers. So this would be your traditional blood test for the same markers. And what we're actually seeing here is the epigenetic biomarkers not only are in some cases they more statistically significant, but in some, which means that they're higher up on the graph, they're also wider. And the wider you are, the higher the hazard ratio or the odds ratio for disease. So in this case, for mortality, we're seeing that not only are we very statistically significant with these markers, but we also have, in some cases, a higher hazard ratio for mortality. Taking it a step further, we also looked at the strongest performing epigenetic biomarkers for mortality and found that many of them actually performed better at predicting mortality at 15 years than the traditional testing counterparts. So here you see in the dark blue are the epigenetic biomarkers, which have odds ratios in the higher ones and twos when compared to their traditional counterparts with odds ratios much closer to zero. So a really interesting effect here where we're seeing, it appears, epigenetic biomarkers are actually better at predicting mortality. And the same was actually true for specific diseases. So here we look at cardiovascular disease, where we see that the epigenetic biomarkers are outperforming or performing as well as the traditional version and then repeating again in cognitive deficit. And we actually did this in multiple different disease states. And what we're learning is not only can we predict the traditional lab values with the epigenetic signature, but that these epigenetic biomarkers themselves are proving to be better at identifying risk through hazard ratio and odd ratio than traditional biomarkers would. So continuing our validation, we wanted to ensure that we're actually measuring the thing that we think we're measuring. We performed a gene ontology study, and that's basically a fancy word for just looking to see which genes are being regulated by the methylation sites selected by the algorithm. Because we're using big AI algorithms here, it's picking the genes that seem to be most associated. Now we're going back and saying, okay, which genes did it pick that seem to be most correlated with those CRP levels, for example? Do they make physiologic sense? Are these genes involved in the biological pathways that align with the outcome that we're studying? And the answer that we found is yes. Here's a few examples of that. So alkaline phosphatase, the methylation version, see we've got the little lowercase m after alk phos, was linked to corticosteroid and glucocorticoid regulation through SMAD3 and CD8A genes, which we know are associated with those things. Hematocrit M was linked to hematopoiesis and leukocyte differentiation, and systolic blood pressure M was associated with peptide hormone secretion pathways. So what we're seeing here is that yes, it does appear that these methylation biomarkers, these epigenetic biomarkers, are linked to genes that make sense for the outcome that we're studying. And we went further to further validate with some clinical application. In this case, we looked at EBP's links to specific conditions and supplements. We found that xanthine M and urate M are elevated in gout, which would make sense because both of those levels should be elevated in gout. So in patients who had gout, we see elevations of those biomarkers. We found that omega-3 supplements increase with DHAM and EPAM, which obviously we would expect. We would want those things to increase if a participant started taking DHA or EPA, and we see that that's the case. We found that when we look at clinical panels, plus things like CBC, CMP, and lipid assays, that the epigenetic biomarkers had an overall accuracy of 90% for detecting out of range biomarkers. And then looking at longitudinal studies, so now tracking patients over 5, 6, 7 different lab draws, we found that the EBPs tracked with traditional biomarkers, with each one of those lab draws. So when the biomarkers increase, the EBPs increase. When the biomarkers stay the same, the EBPs stay the same. And when they decrease, the EBPs decrease. So we're seeing nice tracking over time with the EBPs that we would expect with traditional biomarkers. So what we're finding basically is that epigenetic biomarkers are capable of predicting traditional biomarkers with very good accuracy, that they can predict disease with better than traditional tests, and they pass multiple different rounds of validation. So that brings me to a dirty little secret in diagnostics, which is that no test is 100% accurate. And I bring this up because I think sometimes in medicine we forget this. As I do, especially lab diagnostics. You get a normal CRP, you assume there's no inflammation. You get an elevated hemoglobin A1C, you assume there's diabetes. And I think we easily forget that we get so used to trusting these tests that we forget that sometimes they can be wrong. So let's take a minute and talk about biomarkers in general and tests in general and how we use them as diagnostic tools in medicine, because I think this is going to be important for thinking about how we use epigenetic biomarkers. So what is a biomarker? Simply just a measurable substance found in the blood that provides information about biological processes and diseases, things like hemoglobin A1C, CRP, cholesterol, ApoB. The goal when we order a biomarker is to either one, diagnose disease, two, predict risk of disease, or three, monitor a disease process. So let's talk about an example. When we're diagnosing disease, we tend to talk about sensitivity and specificity, or we combine them and use a term called AUC, or area under the curve, which is sort of this combined performance metric of both sensitivity and specificity. When we think about diabetes, for example, we can look at our three main tests that we use to diagnose diabetes: random glucose, hemoglobin A1C, or oral glucose tolerance test. And if we look at these, we see that sensitivity and specificity is relatively low for random glucose, area under the curve of 0.75. Hemoglobin A1C is better with an AUC of 0.82, and oral glucose tolerance test is the best with an AUC of 0.87. Not perfect though. We're still missing things. I mean, sensitivity specificity is in that like 90% range, right? So you're still going to miss people who actually have a diagnosis, or you're going to diagnose people who don't actually have the disease. So, although predictive power is important, we also have to consider precision and ease of collection. So when we take these three examples, thinking about random glucose, hemoglobin A1C, and oral glucose tolerance test, we don't actually use oral glucose tolerance test much in medicine, even though it's got the best odds ratio and the best AUC. And that's because it's just not really practical. It's hard to get these tests. They cost more for the patient. They have to stay in office for several hours and do two different blood draws. So typically we depend on something like hemoglobin A1C. Now, if we look at our epigenetic biomarker performance, we see that hemoglobin A1C methylation, hemoglobin A1C-M, actually performs better than both glucose and traditional hemoglobin A1C at diagnosing diabetes. So area under the curve, based on the study from Harvard, is 0.844 versus the AUCs for random glucose and hemoglobin A1C, the traditional marker. So we're seeing that it's actually performing better than the standard of what we're using for diagnosing diabetes in medicine currently. And this was true for multiple different disease processes. As I mentioned, there's cardiovascular disease, there's cognitive decline, there's kidney disease, liver disease, COPD. Our biomarkers, in most cases, are outperforming the traditional markers. All 1,600 of them. Not all of them performing, but many of them are. So it actually turns out we're not the first people to create this concept of an epigenetic biomarker. There was a study that in the Lothian birth cohort that looked at developing a CRPM from epigenetic data and found similar results as us. The CRPM was better correlated with cognitive impairment than traditional CRP. And then they also looked to see how precise it was, and they found that CRPM had a 10% improvement in precision to traditional CRP. Then another study in that same cohort actually found that CRPM was more closely associated with brain structure changes on MRI than traditional CRP. So if we take all of that together and we look at comparing CRP to CRPM from their study, this isn't even our data. This is a different study that was specific for CRPM. CRPM performed better in terms of hazard ratio, odds ratio, ICC or precision, and the ease of collection. So basically, what we're talking about and what we've done with the TruHealth report is we've taken those 1,600 biomarkers that we were left with after chiseling away the ones that didn't have a high enough correlation and that didn't weren't associated well enough with disease. We chiseled them even more to the 110 most clinically actionable and best performing biomarkers from that Harvard epigenetic biomarker study. And we put them into one test that is performed at home with a finger stick and can report on all of these things. And we're calling that the True Health Report. So let's now transition to actually let's just go over a report. So I'm going to switch my sharing here for a second so I can share my report. Okay. So this is my True Health report here. And let's just go through it. I want to show this to you guys. So the report, as you can imagine, with 110 biomarkers, not short, but it's packed with lots of great information. So at the very beginning of the report, we explain what epigenetic biomarkers are. So if you're interested in reading that, how they compare to serum levels. We also talk about the Harvard cohort and the data behind how we came up with these biomarkers for True Health. And then we talk a little bit about the actual biomarkers themselves and how to read the report. So here, we're going to present these biomarkers as percentiles, basically. So rather than um, rather than give you an actual number, we're giving you a percentile compared against the rest of the population. And the first section of the report, because there are so many of them, actually categorizes them into their categories and gives you an overall view of how that person's doing it in that category. So for nutrition, for example, we break that up into vitamins, amino acids, antioxidants, fats and cellular membranes. And you can see here, for example, if you combine all of my EBs, my epigenetic biomarkers for vitamins, I'm in the suboptimal range because I'm down in the lower third here. My amino acids are about average, some 50th percentile. So in amino acids, my antioxidants are a little low. I'm in 30th percentile for antioxidants, and then my fats and cellular membranes again are sort of about average. Do the same thing for general health markers. So these are things like lipid peroxidation, serum lipids, blood pressure, metabolic markers, immune markers, neurocognitive markers, inflammation, stress markers, toxins, uric acid pathway, mitochondrial function, oxidative defense, NAD metabolism, ketones, and supplements. So lots of different categories there, lots of great information to help you take care of your patient. There are specific epigenetic biomarkers within each one of these, which then we present later on in the report. But here, this is a nice, like, sort of overview summary of areas that you might want to focus on with your patient. So, for example, if I were looking at myself as a clinician, which I do all the time, you probably shouldn't. I would notice that, all right, looks like I need to focus on vitamins and antioxidants. There's a lot of overlap between those two. That's diet and supplementation related. There's neurocognitive stuff, which is obviously of some concern. Stress, also also a challenge, and then NAD metabolism and supplements. So it just gives you sort of an idea of like where to focus in on your patient. Next up, the next section of the report actually summarizes the most important recommendations for that patient based on the report. So what we do is we take all of the findings of the report and we choose the ones that are the most actionable and then deliver those on this particular page here. So that's what this is. So it's identified in terms of vitamins. B2 or riboflavin is the most important for me. Antioxidants, ergothioneine, valine, oxidative stress marker, pentadecanoate, and an SSSII. And then it gives you recommendations for each one of these. And we'll see these again when we look at the specific EBPs, but there's basically recommendations around like what type of food to eat or lifestyle activities to take on, and then also supplements that can be beneficial for each one of these deficiencies. So let's get to the actual epigenetic biomarkers. This is just a quick page on how to read the epigenetic biomarkers and examples of each one. So some biomarkers are um, the normal range is low, some the normal range is high, and some the normal range is in the middle, right? And this makes sense when you think about it. Like some vitamins, it's okay to have really high levels of vitamins, right? And some things you don't want high levels. You want as low as possible. Like for example, forever chemicals. So there's variation in terms of how we assign the normal range to each one of these EBPs, and this will make sense as we start going through the report. So let's start off with vitamin A. So looking at our vitamins here, we've got the name of the epigenetic biomarker here, vitamin AM. So you'll note that we put an M next to it to make sure that we're denoting that this is a methylation marker, not a blood-derived traditional blood biomarker. So we're deriving this from the epigenetics. And here we see that the normal range is 20 to 100 percentile. So this would be, if you are 100%, that means you're at the top 100th percent of the population. If you're at zero, you're at the 0% of the population, meaning you have the least amount of vitamin A compared to everyone that we compare you to. In this population, we are comparing to the Harvard Mass General cohort. So this is the compared against the 5,000 patients in that data bank. Is who we're comparing to in this population. You'll see a quick description after each one of these epigenetic biomarkers. So the vitamins we kept relatively short because everybody knows what vitamin A is, but basically retinol is an essential for vision, immune function, cellular communication. This is just helpful for communicating with your patients. Also, if they're looking at the report, they'll get some explanation as to what these biomarkers are. And then for some of them, it's actually helpful for us just because some of the names are a little unusual. Next, we see riboflavin. This is a good example of what you see when you have a low biomarker. So we put this indicator here that it's low. Obviously, I'm in the purple. I'm in the 6th percentile for riboflavin. Don't worry, I started taking some riboflavin right after I got this report. And then we've got some recommendations that pop up for any of the times that there is a deficiency. We will identify and visualize in the report the recommendations, both lifestyle and supplement. So in this case, this one's easy. Supplement with riboflavin-rich foods. Here's a couple of foods that are high in riboflavin, and then also obviously take riboflavin or a B complex of some sort. So pretty easy recommendations there. Similar sort of presentation for the other vitamins. We've got B3 in here, B5, B6, B8, vitamin C. We have two different forms of vitamin C, both ascorbic 2 sulfate and ascorbic acid 3 sulfate. So both of those, you can see I'm low in both, 11 percentile and 9 percentile in the other, also taking vitamin C. Vitamin D, vitamin E, choline, and betaine. So these are really nice for assessing methylation and how to go about supplementing for methylation. So, for example, we could give phosphatidylcholine or TMG/betaine. In this case, I would probably lean towards betaine because choline levels appear to be adequate already. So betaine may be a better source for this particular person when attacking their methylation. Next up, so we switch gears there from vitamins to amino acids. Similar sort of presentation with amino acids: methionine, cysteine, methyl methionine, taurine, ergothionine, glutamine, arginine, tyrosine, L-ascorbic acid, valine, asparagine, threonine, valine, glycine, and carnosine. So all of these, there's a few more: cystathione, histidine, and citrulline. So nothing really too interesting, at least on my report for these, but when there is an abnormal value, you'll see it pop up with the recommendation of what foods to eat to get higher levels of that amino acid, or obviously how to easily supplement for that particular amino acid. Next up, we've got antioxidants. You'll see a few repetitions on the antioxidants because obviously some of our vitamins do function as antioxidants as well. Things like vitamin A, B2, vitamin C, vitamin E. Then we also have carotenoids. We've got lutein and carotene-diol on here, as well as acetyl L-carnitine, which is a really nice one to have. I've always often wondered when to supplement with acetyl L-carnitine in my patients, and now we've got an easy test to measure for that. So here you see some example of lifestyle type recommendations. For example, increasing physical activity, which is a great way to increase acetyl-carnitine. Then, of course, you can supplement with acetyl-L-carnitine, where omega-3s are a nice way to increase those levels. And then ergothioneine. Angelica, so I'm going to do questions after we go over the report, and we'll have plenty of time. Don't worry. I should be done here in about 10 minutes, and then we'll do questions. Um, Fat and cellular membranes, omega-3s. So we've got our omega-3M, where we've got here a little bit low on that as well. Recommendations on how to improve omega-3s, DHA, EPA specifically, DPA, omega-6s, linoleic acid. And then we've also got PUFAs, MUFAs, and SFA, as well as pentadecanoate. This is the fatty supplement for anyone out there who's using the fatty supplement. That's C15. That's what pentadecanoate is, or pentadecanoic acid. So nice to have that one, knowing when to supplement that for people, as well as phosphoglycerides and phosphatidylcholine. We also have lipid peroxidation markers. So phospholipase A2 is a really nice one, as well as glutathione peroxidase, getting a sense of what is our oxidative capacity. And decanoate, I can't ever say that one, which is C18, is also a cool one to have. Serum lipids. So this is your traditional lipid profile. ApoB, LDLC. You guys know what this stuff is. LDL particle size, VLDL, ApoA1, HDLC, HDL particle size, total triglycerides. All of these are really interesting. I found particularly the total triglycerides one being extremely helpful, because we typically get total triglycerides fasting. And what we're getting with an epigenetic marker is a better sense of what the patient's total triglycerides are all of the time. So how well their body's utilizing triglycerides, rather than how high their triglycerides get after a fatty meal, for example, versus are they using those triglycerides well, or are they staying relative, or are they increasing, and are they not utilizing them well, which can help us understand metabolic health and how well people utilize different energy sources. We have a blood pressure section where we've got VAA, which you guys are probably familiar with from the Omic Age report, but this is nice to have here as well. In my case, it was low, which is actually typically a good thing for blood pressure. So if it were in the high range, then we'd be more worried about blood pressure. And this low range actually changes your concerns a little bit. And we put some descriptions in there. So here, conversely, low levels of VAA might reflect insufficient phenylalanine metabolism or altered gut microbiome activity. So whenever in doubt, look to the description, especially with these more complicated ones, because we've often given an understanding as to why high or low is considered bad. uh, Phenylacetylglutamine, systolic blood pressure itself. So here we're literally estimating the user's or the patient's systolic blood pressure based on their epigenetic biomarker. So, in that initial cohort from Harvard, we had not just blood biomarkers, but we also had biometrics like systolic blood pressure. So we can actually estimate the actual systolic blood pressure, at least on a percentile basis, from the user in front of us. And here I'm obviously doing pretty well in systolic blood pressure. We've got metabolic health, hemoglobin A1C, glucose, palmyl acetylcarnitine, leptin, and phenylacetylglutamine. We've got immune markers, including white blood cell count, neutrophil, lymphocyte, CRPM, neutrophil to lymphocyte ratio, SII, and CD4 to C8. We've also got some neurocognitive markers, including neurogranin, quinolate, dopamine 3 sulfate, dopamine 4 sulfate, and TGF beta, which, as well as progranulin, which can all be helpful in assessing neurodegenerative risk. And then specific inflammation markers include CRP, IL-6, methionine sulfone, serum amyloid A1 protein, glycoprotein acetyls, and then stress markers like cortisol, adrenal activity, chronic stress, kynurenine, toxins. So these are super nice to have. This is the kind of stuff that you're seeing on a standard toxin panel, like the forever chemicals PFOS, PFOA, um, as well as HPMA and hydroxyfluorine and glyphosate, which is obviously the pesticide, as well as lead exposure. So lots of nice additional things there to assess people's toxic exposure. Then we've got a uric acid pathway. So this is specifically looking at uric acid, xanthine, and allantoin, as well as mitochondrial function, looking at energy balance marker, ATP synthase, energy transfer protein, oxidative defense, including myeloperoxidase, oxidative stress indicator, oxidative damage marker, and then NAD metabolism. So here we've got both a byproduct marker. So this indicates inefficiency in NAD recycling, which for me was high, unfortunately. And then we actually have nicotinamide as well as nicotinamide riboside. So you would look at these in people who are supplementing with NMN or NR. And then we've got 1-MNA, which can be helpful because it's produced by the enzyme NNMT. So if you're looking at recycling pathways, this one can be helpful as well. And then finally, ketones, including beta hydroxybutyrate and acetoacetate, and supplements like alpha ketoglutarate, spermidine, and palmitoyl phenylamide, PEA, which some people are using for pain and anti-inflammation. So that's the report. I know that was quite long. I wanted to show everybody like the breadth of the report. Obviously, we could dive into any one of these in more detail. I just want to go ahead and like present this to everyone so they understand like the depth of the opportunity here. So this is a single test to get all of these markers. Again, the patient's doing it at home, and we're really quite excited about showing you guys this. So I'm going to stop sharing now. And I know I saw couple of hands. And let's see, at least one question. All right, so Janet said, how often do you recommend someone takes this test and how likely are the results pretty consistent versus different? Are there specific recommendations on how someone can improve their markers to be more optimal? Yeah, so I've looked at this specifically, and it looks like we're recommending at this point about 3 months between testing, which is consistent with what we're using for PACE and for our age testing in terms of our recommendations. That's when we see adequate response. I will tell you that the fact that the biomarkers are epigenetic derived rather than blood derived means that they are more stable over longer time frames, which is actually a benefit when we're thinking about chronic disease risk because we're getting better assessment of their actual value rather than a singular time point. But we do find that it changes over the several months range. So 2 to 3 months is an ideal time frame to repeat after doing interventions. And then Marcel says, what about sexual hormones? We're working on sexual hormones. Hormones are a challenge. And the reason hormones are a challenge is because people take them. And we've seen some unusual responses epigenetically to whether someone is taking a hormone or not. So if someone's on estrogen, on TRT, then that messes up the epigenetic profile. So what we're going to have to do basically is build a testing system so that we know whether the user is on the hormone or not, and then that will help us assess what the hormone value is. So we're working on it. We should have that one out hopefully in the next few months. Mark says, how much is the test? Hannah, what's the test for HCPs? I don't know off the top of my head.
Yeah, no worries. Nice to see you, Mark. I hope you're doing well. The test is the same as TruAge. So the wholesale cost is 375. You can get a couple discounted ones if you all want to try this. I'll put my email in the chat so we can get you set up. But remember, if you stock these in office or ship them to one location and order 10 or more at a time, we only charge you $20 per kit up front and the remaining amount when the kit's registered.
Awesome. And Mark, the second part of your question, is there data reflecting positive desired changes in response interventions? Yes. I'm not sure if you saw that slide. When I was going over clinical validation of the study, we looked at response to interventions such as supplements, for example, and we saw good tracking with change to interventions as expected. Janet says, congrats on creating such an amazing test. Thank you, Janet. Bruce says, do we have any idea as to the relative health of the biobank population compared to general American population? So to the general American population, the biobank is a good representation to general American population. I think we will find in general, it is slightly less healthy than the true diagnostic population. And that's just sort of a natural response of people who take the TruDiagnostic age test or the TruHealth test are generally more proactive with their health, and for that reason are going to be slightly healthier. But as in terms of a comparison to the general American public, very good comparison. Are we getting updates for free as new algorithms are being developed? So as we update the True Health, then new True Health tests will have the new algorithms. And as we look back on it, it would change the test results as new algorithms are being developed. That is correct. We would like to use this to detect changes due to an intervention. What is the shortest time frame that has given you a significant change? That depends on the intervention. So this was anonymous attendee, so I don't know who asked this question, but it's going to depend a little bit on the intensity of the intervention and the intervention itself. So really dramatic changes, like for example, fasting, um, a 3-day water fast will give you significant epigenetic changes in the course of a few days. So you would see those. Start taking a supplement, you're looking at a longer time frame. So I would expect to wait at least a month for that. But your safest bet is probably to wait for about 2 months. I would use it in a lot of ways. I mean, similar to how we order blood tests now on our patients. You do an intervention, you let it sort of sit for 2 or 3 months, and then you perform a repeat test. Generally, the user doesn't have tolerance for more regular testing than that anyway. So I think sticking with that schedule of 2 to 3 months is going to be safe. Adrian says this looks like a significantly better report layout than TruAge. The basic report for TruAge was not great and way too simple versus the legacy report. Thanks, Adrian. Appreciate your feedback. Um, we're actually updating the provider report for TruAge, so hopefully you'll like that better. Kevin says, how about dealing with inconsistencies? For example, it looked like the summary of yours showed concerns with stress, but it seemed the stress markers notes in your report didn't reflect concerns unless I missed it. So, Kevin, the reason you're seeing that is because if you remember, my stress marker VAA or VMA was extremely low. So because it was in that like bottom 10th percentile, that popped up as a reason. So it's not an inconsistency. That's ideal that we want that to pop up. And Cynthia said, no question, just ordered this test and aging test for myself and husband, plus all functional clients from here on. Very excited about these tests. Thanks, Cynthia. We're excited too. And anonymous attendee says, would you provide the genes where the methylation changes are seen? I don't think we can do that. That would be like a ridiculously huge report. I mean, we're looking at like literally hundreds of thousands of CPG sites that are affecting these. So I think that would be a little overwhelming for everybody involved. And we're talking like this is very large data sets. So it's very hard to say like this is specifically because of this CPG from this particular gene. Like while we could get to that level of granular detail, it would be overwhelming. Is the data in this report available via API? Yes. Yep. It's available just like aging through our B2 API. Dylan says, are the supplement markers NAD, spermidine, etc., used to titrate supplements? Would someone who is taking those be on the zero low end of the spectrum? Uh, yes. So we've seen positive correlations with those supplements. So we would expect that if you're taking spermidine, for example, your spermidine levels would be higher. The NAD is a little bit more complex because there's multiple different markers looking at NAD. We're looking at not just nicotinamide, but also NR, as well as some of the recycle pathway markers. So it's a little bit more complex, but we would expect the NR and nicotinamide to track with supplements as people are taking them. Considering interventions and lifestyle changes take time, it seems like 6 to 12 month retest would be better time length. I think that's fine, Adrian. You can push to 6 to 12 months if you like. What does your team feel 3 months is sufficient? What makes your team feel 3 months is sufficient? The reason we feel like that's sufficient is because we're seeing change in that short of a time frame. So if you wanted to check at 3 months, and your patient's been compliant. I mean, there's a ton of stuff that goes into this, like how compliant is your patient? Are they actually doing the things that you've asked? Did they start doing them immediately after you had your visit? Like all of those things play into when you retest. So if you feel like 6 to 12 is better for your practice, that's great. Go for it. I think if you want to test as soon as 2 to 3 months, then you would see change. Janet says, you noted that tests are not perfectly accurate. How accurate is this test? More accurate than more accurate than the current blood testing. So this it appears that the with the EBPs that we chose to include in this test, they perform better in terms of predicting disease than the blood biomarkers that are traditionally used to predict those diseases. So if we look like, for example, we talked about CRP and neurocognitive decline. We talked about hemoglobin A1C and diabetes. We talk about ApoB and cardiovascular disease risk. What we're finding is that these EBPs are better predictors. Each one is a little bit different, right? Like the AUC for hemoglobin A1C for diagnosing diabetes was 0.84, and for a traditional blood hemoglobin A1C, it was 0.8. So they're performing better at diagnosing these diseases. We are not publishing every single one of those AUCs because, again, that would be also overwhelming. But the ones that we're using here are performing better than the blood tests. Marcel says, I had the chance to compare actual blood lab tests with EBP and saw that while the actual numbers were borderline for metabolic health, for example, the EBP were indicating higher values. Can we assume that if they do not change their lifestyle, they would go into that direction of developing metabolic dysfunction in that case? I'm not totally following you, Marcel. It sounds like you're seeing that, okay, EBP is showing higher values for metabolic health than the patient's markers. Yeah, so that would indicate that you might be picking up on earlier metabolic disease that's not being picked up yet on traditional blood markers. So my interpretation of that would be that they are more likely to have metabolic disease based on the EBPs as compared to the traditional blood markers. Adrian says, is there a period of time that a person needs to avoid supplementation before testing? It depends on what you want to study, Adrian. So like if you're interested in knowing whether supplementation is adequate at replacing a particular deficiency, then I would just test on supplementation. If you're more interested in what's their baseline, like just sort of think about it like you're doing a Nutri-Eval or something like that, then you could have them stop for, probably 2 weeks, but it might need to be more like a month. Traditionally, I'm using these while the patient's on supplementation because I want to know if the supplementation I'm performing is adequate or not. Can you please comment on the test reliability, internal consistency? Yes, I think. I don't know that I have any specific numbers for you, Michael, but we're constantly monitoring our own internal consistency and reliability, as well as testing ICCs on all of these values. So that's something that we're always working on, and it's performing extremely well. Precision on these markers is in the high 90s. So we've been really happy so far with performance. Kevin says, in a perfect patient world, how would I pair this test with the true age test? Have you found good correlation with Symphony results and TruHealth corollaries? This does look like a great treat, and I love the useful guidance with abnormalities. Nice job. Thanks, Kevin. Yeah, I think like the way I'm currently using this test is pairing it with a true age test and using that to help further refine interventions um, uh, uh, for aging. So, say for example, somebody has a higher omic age. There's obviously an opportunity for improvement in terms of the speed at which they're aging. Maybe their pace is 1.3, something like that. I'm using a combination, obviously, of the things that we already have, like looking at the organ system health with Symphony Age, and then also using True Health and looking at those opportunities for improvement on True Health because we have sort of a systems approach to True Health as well. So I combine all of them together when I'm assessing like the most important interventions for the user. Thanks, Kevin. Is Zymogen a company you recommend? I can't comment on Zymogen. Sorry, Cynthia. I know a lot of people use Zymogen. Mark Sue, good stuff. Thanks for this overview. Good balanced presentation, Dr. Mallin, with high level versus detailed complexity. Thanks, Mark. Hi to you also, Hannah. Keep up the great work, Trudy. Thanks, Mark. All right. Unless there's any other questions, I think we'll call it a wrap, everybody. Awesome. Well, Blaine, this is great. Love being able to see data on some of the newer measures for longevity supplements like C15, inability to check urolithin A. I wish. Yeah, we did. We don't have metabolomic or proteomic data on urolithin, unfortunately, so we couldn't pull that one together. That was one of the ones on my list as well, too, Blaine. But we'll have to add that one. We are looking to, so just to talk a little bit about the future. So we're actually looking to continue expanding this list. We're at 110 biomarkers now. We are planning on adding to it. We'd love to add hormones. We're also looking really closely at organic acids. And there's a few other biomarkers, like as things come on the market, as we go through the list of things that we would like to add. We're currently working on that. We have to collect the data. We have to, well, create the list first and then collect the data, and we will be updating the report. I don't really have a great timeline for you right now on when that's going to happen, but it'll continue to happen and it'll be perpetual. Like just like we've done with age over the years, as new algorithms come out that we can improve, our ability to assess biological age, we'll be doing the same thing with TruHealth. So as our ability to predict these epigenetic biomarkers improves, we will continue to expand the report. We'll probably focus in on those biomarkers that seem most actionable based on feedback from you guys. We'll add the ones that we and you think are the most important. So this will be a continually, ebbing, flowing process, just like it has been in the past. This is all science backed. As the science changes, our reports are going to change, and that's our ethos. That'll continue to be our ethos. Thanks, Blaine. All right. Mark says he'd love to see organic acids included. I agree. All right, everybody. We really appreciate your time. Got you 7 minutes out of here early so everybody can get to bed and get some sleep and improve their biological age. Thanks, everybody. Have a great one.